Hello, everyone, and welcome to ISGyP Live's February 2021 Journal Club. I'm your moderator, Natalie Benet, and just as a disclosure, this webinar is being recorded. So while folks are joining the meeting, I'd like to let everyone know about upcoming events for ISGyP Live, including a March 4th webinar titled Neoplastic and Non-Neoplastic Lesions of Intermediate Trophoblast Origin with Dr. Koo-Rae Kim. And that will take place at a different time than the normal 12 noon Eastern time. So this will be at 7 a.m. GMT, 4 p.m. Seoul time. So make a note of that change. And then on March 11th, there will be a slide seminar titled A Practical Approach to Borderline Tumors of the Ovary with Dr. Philip Ip. And stay tuned for a time on that. ISGyP Live is making an effort to expand opportunities for participation to a more global audience. So please keep an eye out for time changes to your favorite events, including webinars, slide sessions, and journal clubs. Accurate times will be placed in the ISGyP monthly email for members, as well as on isgyp.ca, where you can register for these events, and also on Twitter. So recordings of the journal club will still continue to be available on YouTube, and the webinars and slideshows will still be available for members on isgyp.ca. Realizing that the live sessions will not be practical for all parts of the world to view in a live format, the ISGyP Live Working Group is also hard at work on ways to make the recordings of meetings available to everyone for a period of time. So stay tuned, watch your email and Twitter, and that will be the email you use to register for the webinar about how you can access those recordings. Okay, so these are the standard learning objectives for Journal Club, which still apply today, even though the format has changed slightly. Normally, pathologists and trainees use this format to evaluate selected articles written by other folks, but today, in anticipation of next month's USCAP meeting, the format has changed. So we welcome 3 presenters who were first authors on abstracts at the 2020 USCAP meeting who have subsequently had their work published. So it's my pleasure to introduce Dr. Megan Dibbern, who is a PGY3 at the University of Virginia, and she was also awarded the W. Duane Lawrence Award for her platform presentation at the 2020 USCAP meeting. Also, Dr. Simona Stolnicu, who is a professor at the University of Medicine, Pharmacy, Sciences, and Technology of Targu, Mures in Romania. And finally, Dr. Kelly Devereaux, who is a molecular genetic pathology fellow at Memorial Sloan Kettering Cancer Center and was previously a GYN pathology fellow at Stanford. And also on the call today are Drs. Ann Mills and Kay Park, who were the senior authors on respectively Dr. Dibbern and Dr. Stolniku's papers. So thank you all of you for being here with us today. So we will follow a similar schedule to our normal journal clubs with a presentation from each of our 3 pathologists, similar to what they likely showed at the USCAP meeting. And at the close of the meeting, we will have a panel discussion about the experiences of the first authors regarding presenting at USCAP, publication, and tips for manuscript presentation. And just as a housekeeping note, this is a webinar format. So for those in the audience, please place questions for the presenters in the Q&A section, which is located at the bottom of your screen in the black bar. And you may prioritize other folks' questions. If you click on that Q&A and see one you like, you can click the thumbs up button. And now we can go to our first presenter, Dr. Dibbern. You are welcome to share your screen.
All right. I think we all should be looking at my PowerPoint. So thanks, Dr. Benet, for the fun introduction. I'm Meg Dibbern, 3rd-year resident at the University of Virginia Medical Center. I'm really excited to be here. So we'll be talking about loss of MHC class 1 expression in HPV-associated cervical and vulvar neoplasia as a potential mechanism of resistance to checkpoint inhibition. And this came out this past fall in the American Journal of Surgical Pathology. So before we get into the nitty-gritty, a couple acronyms that'll be peppered throughout the talk. Human papillomavirus is HPV, major histocompatibility complex class 1 is MHC class 1 or MHC1, programmed cell death 1 and programmed cell death ligand 1 are PD1 and PDL1, squamous cell carcinoma is SCC, squamous centroepithelial lesion is SIL. All right, so study design, or as I like to think of it, the what, but, so what. So what is the issue? So therapies targeting the PD-1 and PD-L1 immunotherapeutic axis have shown really promising results as treatment for certain solid tumors, including advanced stage cervical and vulvar squamous cell carcinomas, which historically have had very few treatment options when they reach that advanced stage. And that has led to a recent FDA approval for the use of pembrolizumab, which is a PD-1 inhibitor, as a monotherapy for these advanced stage or metastatic cervical cancers. But in practice, among those cervical squamous cell carcinomas that have met the FDA-approved threshold for pembrolizumab therapy, we've actually seen a fairly limited response, and that brings the question why. So we're targeting the immune system as a way to treat these tumors. So going back to basic, just the two immune arms of the immune system, we looked at MHC class 1. Which is part of all normal cells in the human body that are required for antigen presentation and interaction with that adaptive immune system that's targeted by pembrolizumab therapy. And alterations in MHC class 1 expression have been seen in both cervical and vulvar squamous cell carcinomas. And in other types of tumors, they've found a link between MHC class 1 expression or downregulation and failure or resistance to PD-1 or PD-L1 checkpoint therapy. So no prior studies have actually looked at that relationship specifically between MHC class 1 and PD-L1 expression in cervical and vulvar cancers. So that's what we did. We chose HPV-associated lesions, both intraepithelial and invasive, to look at the MHC class 1 and PD-L1 expression. And from our findings, we're positing that loss of MHC class 1 and assessing for that loss can actually optimize selection of those high-grade or advanced stage cancers for better or more effective immunotherapy. So what did we do? We chose 58 HPV-associated treatment-naive cervical and vulvar lesions, and we confirmed that HPV association with P16 staining in our vulvar tumors, and that included 27 CILs and 31 invasive carcinomas. Those cases, we stained for MHC class 1 using an antibody that targets the combined A, B, and C heavy chains, and we also stained for PD-L1. And then our statistical analyses were performed using a two-tailed Fisher exact test. So to assess our immunohistochemistry, the MHC class 1 staining was divided into 3 tiers, where it was either called intact with membranous staining present in all tumor cells, clonally lost, where you had loss of expression in a discrete population of neoplastic cells adjacent to areas that had clear intact staining, or completely absent, where you just didn't have any membranous expression of MHC class 1 in the tumor. And our PD-L1 scoring was performed using the combined positive score, which takes the number of positive tumor cells, lymphocytes, and macrophages, divides that sum by the total number of tumor cells, and multiplies it all by 100. And that gets scored contiguously from 0 to 100, with any PD-L1 expression of at least 1 being considered positive. So what did we find? MHC class 1 expression just at baseline, we found was intact in normal squamous epithelium, which you can really see here in the basal layer, also in the stromal cells and just normal inflammatory cells. But going to our lesions, among our CILs, we found that 19% of these showed loss of MHC class 1 in a clonal pattern. And that's illustrated in figure 1, where the lesion shown in C and D demonstrates diffuse expression of MHC class 1, to contrast with the lesion shown in E and F, which shows a clonal loss of MHC class 1 in a portion of the tumor. Then moving on to our squamous cell carcinomas, we found that more than a third, so 29 plus 6.5%, showed loss of MHC class 1 expression in both clonal and complete loss patterns. And that was illustrated in figure 2, where in part A, we have a lesion showing complete intact expression of MHC class 1. The lesion in C and D shows expression in a portion of the tumor with abrupt loss in a clonal pattern on the right-hand side, and the lesion in part E and F showing complete loss of MHC class 1 expression, but you can still see retained expression in the intervening stroma and those tumor-infiltrating inflammatory cells. Looking at PD-L1 expression then, in our intraepithelial lesions, we found that up to a quarter of our cases showed PD-L1 expression at a CPS threshold of at least 1. And as we moved up the thresholds, we lost PD-L1 expression, and we didn't see a significant difference between our SYN3 and VIN3 cases. Looking at our squamous cell carcinomas, actually the majority of our lesions showed PD-L1 expression at a CPS threshold of 1, 84%. And even moving up to a CPS threshold of 100, you can see that almost 20% of our lesions showed PD-L1 expression, again, with no statistical difference between the cervical and vulvar cancers. And finally, looking at MHC and PD-L1 expression together. In our SIL cases, you can see that there wasn't a very significant difference between our PD-L1 positive and PD-L1 negative cohorts, where 19 versus 20% of cases showed MHC class 1 loss. But in our in our squamous cell carcinoma cases, we saw a more pronounced difference, where we had almost 40% of our PD-L1 positive lesions showing some form of MHC class 1 loss compared to 20% in our PD-L1 negative lesions. And looking at our different CPS thresholds, you can see that that trend holds, ranging from 30 to 40% of our PD-L1 positive lesions showing MHC class 1 loss, compared to between 10 to 30% of our PD-L1 negative lesions. And even at a threshold, CPS threshold of 100, we still had a third of our PD-L1 positive cases showing MHC class 1 loss. So coming back to what our findings mean and how they relate to our original question of PD-L1 immunotherapy, just at baseline, evasion of the adaptive immune system is really important for survival of many malignancies. And in our case, the expression of PD-L1 on tumor cells helps them cloak, almost like an invisibility cloak if you're into Harry Potter, cloak themselves from notice by those host cytotoxic T cells. And immunotherapy works by ripping off the invisibility cloak and allowing those host immune cells to recognize and attack the malignant cells. And so in theory, that sounds perfect. You antagonize that PD-1, PD-L1 expression, and it should be good to go. But in practice, the cervical squamous cell carcinoma cases that met that FDA threshold for treatment with immunotherapy showed a pretty limited response. Only 12% had an overall response, and actually only 3% showed a complete response to therapy. And so the idea is that that lack of response to what should have been an effective treatment is probably due in part at least to concomitant expression of other immunoinhibitory molecules. And that goes back to the success of immunotherapy that's targeting the adaptive immune system, which is looking at those cytotoxic CD8 positive T cells, has to have MHC class 1 expression. Because MHC class 1 is the flagpole that's on all cells in the human body, where the cells wave their self or non-self antigens, and that is what the T cells recognize and in turn are activated by and attack those non-self cells. So if you're trying to unmask tumors by inhibiting the PD-1, PD-L1 axis, it isn't going to work because the flagpole that the T cells need to recognize those cells as non-self is absent. And so what we found is that a significant subset of our HPV-associated PD-L1 positive lesions that would meet the qualifier to be treated with immunotherapy don't have MHC class 1 expression. And so that is a clinically important barrier to anti-PD-1 therapy. And to illustrate that, here we've got two cases of cervical squamous cell carcinoma. The first here shows strong diffuse PD-L1 expression and strong diffuse expression of MHC class 1, suggesting that this case would still be vulnerable to that PD-1 inhibition therapy. In contrast, here you have a cervical squamous cell carcinoma that still has PD-L1 expression, but loss of MHC class 1 expression in the tumor cells, indicating that they would probably be a poor candidate for pembrolizumab therapy, even though they meet the threshold for PD-L1 positivity. Similarly, in our vulvar squamous cell carcinoma cases, here's a case that has PD-L1 expression that meets that CPS threshold and MHC class 1 expression, indicating this would probably be a good candidate for anti-PD-1 therapy. And in contrast, vulvar squamous cell carcinoma that still barely meets that PD-1 threshold based on tumor cell positivity, or inflammatory cell positivity, but with diffuse loss of MHC class 1, indicating this tumor probably isn't going to engage with the adaptive immune system as is expected with pembrolizumab therapy. So this is important because the relationship between MHC class 1 and PD-L1 expression has been looked at fairly thoroughly in other tumor types, including head and neck, lung cancers, gastric cancers, Merkel cell. And what they found is interesting. In cases that have PD-L1 expression but loss of MHC class 1 expression, those often are associated with larger tumor sizes, metastasis, lower T cell tumor infiltration, and just an overall poor prognosis. So this supports the idea that MHC class 1 loss represents a significant challenge to immunotherapy in cases that are being targeted to rev up that adaptive immune response. Other studies have shown that MHC class I downregulation in HPV-positive cells is accomplished via an E7-dependent manner. And that brings up the idea that specifically in HPV-associated malignancies, MHC class I downregulation may be a really important, an especially important methodology to evade the immune system. Other studies have looked at ways to kind of re-express MHC class I in order to sensitize tumors like Merkel cell and B-cell lymphomas, where MHC class I loss is due to epigenetic factors. And so treatment with histone deacetylase inhibitors has kind of re-expressed MHC class I and resensitized those tumors to anti-PD-1 therapy. But overall, the takeaway points from our paper, what we showed is that over a third of our HPV-associated cervical and vulvar squamous cell carcinomas showed either clonal or complete loss of MHC class I expression, including those cases that were PD-L1 positive and met the threshold for the FDA-approved pembrolizumab therapy. And that leads us to the idea that in these tumors that have loss of MHC class I, their response to anti-PD-1 or PD-L1 therapy would be impaired because they're not able to engage with the adaptive immune system because of that loss of MHC class I. And therefore, we're supporting that MHC class I is a useful biomarker in optimizing the selection of these cases for immunotherapy. Some of the limitations of our paper, the first is that we only looked at the MHC class I heavy chains. So MHC class I has 4 parts, the A, B, and C heavy chains, and also a beta-2 microglobulin light chain, which is an important part, and you can't have function if you lose that light chain. In some cases of melanoma that's been treated with pembrolizumab therapy, it's been shown that they downregulate MHC class I expression via loss of that beta-2 microglobulin. And so that suggests that tumors can adapt to anti-PD-1 therapy and change their expression of MHC class I. It also brings us to our next limitation of this study, which was we only looked at treatment-naive specimens. So it would be really interesting to look at the MHC class I expression pre and post-treatment with immunotherapy in lesions. And this is actually something that we're looking at pursuing this spring, which is pretty exciting. And then the last thing is we only looked at HPV-associated tumors. And we know that HPV-associated and HPV-independent lesions have very different pathogeneses to arrive at malignancy. And so it would be really interesting to see how MHC class I fits into that HPV-independent process. Some studies have looked at PD-L1 expression comparing HPV-independent and HPV-associated lesions and haven't found a major difference, but MHC class I expression hasn't been thoroughly investigated in that context. And that's all I got.
Thank you, Dr. Dibbern. That was very well done. And I can tell it's been through the USCAP platform grinder because it was tight. It was perfect. So I do have a few questions. We don't have any in the Q. Oh, there is one in the Q&A, which I will take a quick. Oh, someone said thank you.
Yeah,
so
sorry, I tried to answer a couple in there in case we were low on time, but I'm happy.
Oh, no, thank you. I'm happy to have help. So, so you said you're looking at pre and post therapy specimens. I think that'll be really interesting. And also maybe primary and metastatic lesions from the same tumor. That would be very interesting to see if those evolve. Just a thought that I had. And then you said that this is sort of being investigated along with PD-L1, and I know PD-L1 was one of those things that wasn't really being done, and then all of a sudden, you know, it got approved, and then everyone wanted it on everything. So, do you have clinicians asking for this for the MHC staining, or is that something that you think is going to be looked at in trials alongside with PD-L1 in the future? I'm sure you and Anne can answer this. Dr. Mills.
Yeah, as far as my experience with our cases, we haven't had clinicians asking for MHC class I expression, but I would expect that is coming down the pipeline with more and more studies showing an association with other immunomodulatory factors being taken into consideration for PD-L1 kind of as that threshold for immunotherapy.
Yeah, because like you said, the response rate is pretty low, right? Even though we know and often these patients don't have other options, right? Often when they make it to the point of getting a PD-L1 test, it's because they're recurrent or resistant or, you know, metastatic or something where they're kind of not grasping at straws, but sort of looking for all opportunities.
And there are studies looking at combinations of immunotherapy. So PD-L1 isn't the only immunoinhibitory molecule. There's others, and you could use a combination therapy. But again, if your tumor is not able to interact with your adaptive immune system, it probably isn't going to work very well.
Someone did ask, what do you think would be the impact of loss of MHC class 1 on overall prognosis, regardless of PD-L1 status? Didn't you say that that had been looked at in other tumors?
In some of the head and neck and gastric and skin lesions, I'm trying to remember specifically, loss of MHC class 1 usually portends a worse prognosis overall, but especially in PD-L1 lesions. I don't know, Dr. Mills, if you have other input.
No, that's beautiful. And I realize I'm causing problems in the chat. I accidentally said I answered something live when I didn't. So I will answer it live now. We have accumulated a few dozen patients with cervical squamous cell carcinoma who have now been treated with pembrolizumab. As Dr. Dibbern emphasizes, that we want to look at them. I think our oncologists are of the mind that they'll offer pembro irrespective of what this early data shows, because there are just so few options for these people. So on some level, they don't really care yet what this stain would show. And even if we find that loss of MHC class 1 is a significant indicator of poor response, I still don't think they'll care, because they are so eager to give these women an option. But you know, over time, it may be that this sort of hype surrounding pembrolizumab in this setting diminishes if we continue to see, you know, poor responses and also side effects, and they may then become more interested, because it's not a no penalty drug to give. There's a lot of, you know, immune activation related symptoms that they can get.
Yeah, and being able to fine tune who will and won't respond, especially if there are other options available down the road and they can pick from. Right now, it's almost the only thing on the menu some of the time, right? So like you said, they give it irrespective of the results. So why did you include high-grade SIL in your study? Obviously, you wouldn't treat that with pembrolizumab. I thought do you want to address that question, Dr. Dibbern?
Yeah, just the idea that once something kind of tips over from being in situ to an invasive lesion, there are other genetic and epigenetic changes that happen. I think just to see from an in situ to an invasive lesion, what does MHC class 1 expression look like? And PD-L1 shows a difference as well. So that makes sense to me. So, okay, so we'll move on now, just in the interest of time. That was excellent. Thank you so much. Dr. Stolnicu, you're up, so you can share your screen.
Just okay. Thank you very much for the invitation, first of all. The paper I'm going to talk today has been published in American Journal of Surgical Pathology 2020 and is entitled Invasive Stratified Mucinous Carcinoma of the Cervix Often Presents with High-Risk Features That Are Determinants of Poor Outcome, an International Multicentric Study. And as you can see here, I was the first author. The senior author was Kay Park from MSKCC. The study was conducted at MSKCC, but we managed to collect cases from multiple international institutions. As you know, the incidence of endocervical adenocarcinoma has increased in the last decades, and in 2018, a new classification proposal was published in American Journal of Surgical Pathology called International Endocervical Adenocarcinoma Criteria and Classification, IACC, and this classification has been integrated into the latest WHO classification of tumors, the female genital tumors, that was published in September 2020. And based on both classifications, invasive endocervical adenocarcinomas are now classified into two groups, HPV-associated and HPV-independent. And within HPV-associated, we can find the usual type, mucinous type, and adenocarcinoma NOS. And regarding the mucinous type, there are 4 subtypes that are recognized: NOS, intestinal, signet ring cell, and invasive SMILE or invasive stratified mucinous carcinomas. And this is a new described entity, actually, that I'm going to talk about today. And the study was based on this new type of tumor. But let's start with the precursor lesion with stratified mucin producing intraepithelial lesion that is a variant pattern of in situ endocervical adenocarcinoma described back in time by Dr. Park in 2000 and included in the in situ endocervical adenocarcinoma by the latest WHO 2020 classification. It is thought to arise from HPV-infected reserve cells of the transformation zone and being composed of atypical cells containing intracytoplasmic mucin stratified throughout the entire epithelial thickness. It has a hybrid morphology that can mimic high-grade squamous intraepithelial lesion and can be associated with HSIL as well as HPV-associated in situ adenocarcinoma and various types of invasive carcinomas. And later on, 2016, Dr. Lastra published the first series of cases, which are thought to be the invasive counterpart to SMILE, and which he called invasive stratified mucinous carcinoma or invasive SMILE. These tumors are always HPV and P16 positive. Electron microscopy studies reveal that there is a stratified structure with mucin vacuoles, abundant mitochondria, no tonofilaments, suggesting glandular differentiation. But this tumor has a different immunohistochemical profile from other HPV-associated endocervical adenocarcinomas, with P40 and P63 often expressed in the peripheral palisade, a significant subset of cases showing mutation type P53 staining, and less frequent PAX8. And also the morphology is different. Usually and classically, it is represented by nests of columnar cells, variable amount of intracytoplasmic mucin, nuclear peripheral palisading, apoptotic bodies and mitosis are present, neutrophilic infiltrate is present, and can be seen as pure or mixed with other morphologies. But then we have also described that there is architectural diversity encountered in invasive SMILE with insular, glandular, solid papillary, trabecular, micropapillary, cytologic diversity, signet ring-like, cytoplasmic, cleric, eosinophilic cytoplasm, histiocytoid or glassy cell-like, and other findings such as bizarre nuclear atypia, pulse of mucin, hyaline-like globules, and squamate differentiation. Also, from the molecular point of view that is currently being investigated, the paper presented by Dr. Paraharan at the USCAP in 2018 showed that these cases may present STK11 alterations, and the impact study that is running at MSK-CC is showing this tumor associated with multiple genes amplified, deleted, mutated, and gene rearrangements. Although this is unpublished data. So this tumor may be also biologically different from other HPV-associated adenocarcinomas. So all these problems were interesting, but nobody actually was focused on the survival. And looking at the small series of cases that were presented and published before in the literature, we have realized that, for example, in the original paper of Dr. Lastra, 2 out of 4 cases presented with lung metastases, 1 out of 4 with widespread abdominal pelvic disease, and 1 out of 4 died of disease. Then the study by Dr. Angelica Hodson revealed that these tumors had worse disease-free survival and disease-specific survival compared to other HPV-associated types, even in univariate analysis. And more recently, Dr. Horn, presenting and publishing about 5 cases and also summarizing the data from literature, concluded that these tumors are at presentation, at diagnosis, have large size, are associated with pelvic lymph node metastasis, all of them with pelvic and 2 with distant recurrences, and they may really represent an aggressive subtype with early recurrence and risk of distant metastasis into the lungs. 4 out of 5 patients died of disease. So we thought to investigate the outcome in invasive SMILE compared to usual type endocervical adenocarcinomas to determine which clinical pathological parameters may influence the prognosis in a large multi-institutional international series of 52 cases. So this was the aim of our study. We have collected 52 cases And all the H&E slides containing tumor, average of 12 slides per case, were examined at a multi-headed microscope, and a consensus diagnosis was reached in every case with at least 2, as many as 4 pathologists, and the HPV testing was done by in situ hybridization, except 7 cases from Germany, which were studied with PCR. We have classified these 52 cases according to IACC classification criteria. And whenever invasive smile represented more than 90% of the entire tumor, we call these tumors pure invasive smiles, and we have 29 cases. And whenever the invasive smile component was more than 10 but less than 90% of the entire tumor, we call them mixed invasive smiles, and we had 23 cases, 13 associated with the usual type, 3 cases with mucinous NOS, 6 cases with adenosquamous carcinoma, and 1 case with neuroendocrine carcinoma. Then we have collected data regarding age, FIGO stage, treatment, HPV status, tumor size, histological grade, LVI, Silva pattern of invasion, lymph node metastasis, local pelvic recurrences, overall survival, and recurrence-free survival. And we use Kaplan-Meier for survival curve estimates, log, rank, mental Cox text to compare groups, hazard ratios, and 95% confidence intervals or estimated using the Cox proportional hazards regression model, and P less than 0.05 was considered statistically significant. Results of the high-risk HPV testing: 44 out of 45 cases tested by in situ hybridization were positive, and 6 out of 7 cases tested by PCR were positive, and most prevalent high-risk HPV subtype was 18 in our study. Also, comparison of clinico-pathological parameters in pure versus mixed invasive smile cases showed no significant statistical association regarding age, FIGO stage, tumor size, LVI, Silva pattern of invasion, and lymph node metastasis. But with this being said, pure invasive smiles were more likely to have a large size at diagnosis, to be at higher stage of diagnosis, and to be associated with LVI, Silva pattern C of invasion, and lymph node metastasis. Also, no statistically significant statistical association in pure versus mixed invasive smiles regarding local pelvic recurrences, adjuvant therapy, HPV status, and outcome, but significant statistical association regarding radical surgery with or without lymph node dissection. We have previously demonstrated that there is no significant differences in overall survival and recurrence-free survival between pure and mixed invasive smiles, but in a small series of cases. So the current study actually showed same, very similar results. There is no statistically significant differences in overall survival and recurrence-free survival between pure and mixed invasive smiles. Determinants of outcome, overall survival and recurrence-free survival at 5 years were statistically different in advanced stages, 2 to 4 versus FIGO stage 1. And using mathematical Cox analysis, overall survival was influenced by FIGO stage, tumor size, lymph node metastasis, local recurrences, while recurrence-free survival was influenced by FIGO stage, tumor size, lymph node metastasis, local recurrence, and lymph node dissection. There are well-known prognostic parameters in endocervical adenocarcinomas demonstrated by previous studies: FIGO stage, LVI, pelvic aortic lymph node metastasis, and distant metastasis. And in concordance with previous studies, we have also shown that invasive smile is associated in about half of the cases with LVI, in about 1/3 of the cases with lymph node metastasis, 25% of cases with local recurrences, 7.6% of cases with distant recurrences, and 13.4% of cases died of disease. In the current study, metastatic site diagnosis was represented by lymph nodes, ovary, and peritoneum, and recurrent sites by ureter, liver, small and large bowel, vagina, parametrium, pelvis, scalp, inguinal lymph nodes, and lungs. Also, comparison of clinico-pathologic features in invasive smiles versus the usual type HPV-associated adenocarcinomas show significant statistical differences regarding lymph node metastasis, with invasive smiles associated with 33% of cases with lymph node metastasis versus 12% the usual type. Local recurrences, 25% of invasive smiles presented local recurrences, and only 8.8% of cases of usual type presented with local recurrences. Advanced stage of diagnosis, 30% of invasive smiles were at an advanced stage of diagnosis, comparing to 14% of cases of usual type. And Silva C pattern of invasion, 92% of invasive smiles were of Silva C pattern, and only 76% of usual type were of Silva C pattern of invasion. So invasive stratified mucinous carcinoma is different from other HPV-associated adenocarcinomas regarding morphology, immunohistochemical profile, and biology. It is a tumor which has propensity for advanced stage LVI, lymph node metastasis, destructive stromal invasion, and local distant recurrences, regardless the extent of the invasive smile component. Which are the applications and areas of improvement. Regarding applications, the pathology should be aware of this new entity, which has different morphology and a different prognosis. Invasive smile should be reported in any percentage and should be treated more aggressively. And this is a recommendation which has been included into the upcoming paper of ISGyP International Endocervical Adenocarcinoma Project that will be published very soon, probably next month, in International Journal of Gynecologic Pathology. Regarding the treatment, the more aggressive treatment, surgical treatment should be represented by radical surgery and lymph node dissection, irrespective of the size of the tumor and percentage of the tumor represented by invasive smile component. Also, since the type of the surgical treatment is such an important determinant of outcome in invasive smiles. And areas of improvement, we need more numbers for statistical strength. Thank you very much.
Thank you. Thank you for that presentation. That was wonderful. I like the paper that comes after yours is about a similar, it's not a similar tumor, but it also required collaboration. So I wondered if you could just talk a little bit about what it was like to bring all these folks together for these 52 cases. It requires, and I know I see Dr. Park has turned her camera on as well, but it requires sharing across academic institutions, countries, and everything. So can you just talk a little bit about what that was like?
Yeah, so some of the cases that have been included into the study were retrieved from the ICC original cohort. So when we started to work on this tumor and the cervical adenocarcinomas, we realized that some of them are of invasive smile subtype. And then when we started to think about publishing related to morphology and specifically related to this study to the prognosis, we realized that we need more cases. So we have involved more people that we knew actually, and involving people is great because they can share cases from all over the world. The thing is that they have to have follow-up to start with, and then you have to review all the cases. So this is what we have done. We have reviewed all the cases and had a consensus on each case, and then just put the data together and draw the conclusion. Yeah. But as you said, it's wonderful to involve people from all over the world and to have multiple ideas of what to do with the cases.
Yeah, that's really interesting. And then also, I'm wondering, a certain component of your cases were mixed carcinomas with other kinds, with invasive smile, and then other kinds of carcinoma. I'm wondering, how often were these hysterectomy specimens in most of your cases, or were some of them biopsies? Because I'm wondering if you have a biopsy and maybe SMILE isn't recognized on the biopsy and then it's present in the hysterectomy, they've already designed the surgery. So were most of your hysterectomies had lymph node dissections up front when the clinicians knew that it was SMILE, or is that something you would advise if the biopsy, you know, because sometimes they try to do sentinel lymph node biopsy, and I assume that's not a good plan for SMILE. So
No.
what was your experience with that?
So all our cases were hysterectomies with lymph node dissection. That was a requirement for, you know, the ISCC study.
Okay.
But I agree with you that in many centers they start with the biopsy and then they decide the treatment accordingly. So whenever we see any percentage of invasive SMILE in a biopsy, we should alert the clinician actually and ask him to perform lymphadenectomy, because these tumors are always or almost always associated with lymph node metastasis and poor prognosis. So so this is the new entry, and then the same is for the micropapillary carcinoma. So these are both new entries of HPV-associated invasive adenocarcinomas, and in both of them, recent studies suggested that they are very aggressive.
Yes.
If I may, you know, coming from a center that does pretty much only sentinel lymph nodes for cervical cancer, they very rarely do lymph node dissections, and I think now it's pretty well established that sentinel nodes is a good alternative, even in aggressive tumors. I don't think lymphadenectomy necessarily increases survival for any of these patients. And yes, you know, we think these are more aggressive, but a lot of patients who are young and want to retain their fertility may have a component of SMILE. And I'm not sure that we should necessarily say they need a complete radical hysterectomy with lymph node dissection, even in those settings. So I know that with us, you know, we still take into account patient age, the desire for fertility. We do tracheolectomies and sentinel lymph nodes. I think what's going to be important is, you know, going forward, looking at the molecular alterations that drive these tumors. You know, are there certain genetics that make them more aggressive? Probably. And as we've shown, you know, maybe P53 is a part of that, because these tumors tend to have more P53 abnormalities by immunohistochemistry. And those are all things that need to happen sort of going forward. But this is just to sort of keep it on people's radars so that we can study these more going into the future.
Yeah. And I assume when you make this diagnosis that you all have to either have a discussion with clinicians or put a note, because sometimes when we come up with these new subtypes, the clinicians think, what are they talking about? You know, so I assume there's a canned text or something that you all have well prepared at this point, even though these are rare. So, okay, thank you, Dr. Stolnicu. We can, you can stop sharing your screen and we can go to Dr. Devereaux.
Can you see my screen okay?
Yes.
Okay, awesome. All right, so I just want to say thank you so much, Dr. Benet and ISGyP, for the opportunity to share our work today on pregnancy-associated IMTs. I'm Kelly Devereaux, a molecular pathology fellow at Memorial Sloan Kettering. And the idea for this project really originated, probably as many projects do, which is that we experienced a sudden clustering or bolus of these pregnancy-associated IMTs at Stanford within about a year or two, which got us intrigued. And we became interested because inflammatory myofibroblastic tumors, or IMTs, are tumors considered of intermediate malignant potential by the WHO, given that a minority of tumors recur and metastasize. And oncogenesis is driven by receptor tyrosine kinase rearrangements, mainly in ALK, but also in others like RET and ROS. And there's been a recent growing recognition of uterine IMTs, many of which that have been historically misclassified as smooth muscle tumors. But there was very limited reporting or understanding of the subset of uterine IMTs that were arising in the setting of pregnancy. And what we noticed was that these tumors were basically shedding or falling out during pregnancy, or in other words, they're acting very differently from the other uterine IMTs that we had been studying. So the goal of the study was really to determine whether pregnancy-associated IMTs are clinically and or biologically distinct from non-pregnancy-associated IMTs. And as far as methods goes, this was really a characterization type of study. We were able to find 8 cases of pregnancy-associated IMTs in our archives by searching terms such as IMT or myxoid neoplasm or leiomyoma. And once we had our cohort together, my friend and co-resident Megan Fitzpatrick helped me with the clinical and morphologic review along with Dr. Longacre. And then we performed an immunophenotypic, cytogenetic, and molecular characterization of these tumors. So here were the results that we found. When we started to put together the clinical data, what was very striking is that all the patients had alterations in pregnancy physiology and/or perinatal complications, which included complications such as preeclampsia, gestational diabetes, antiphospholipid syndrome, abnormal implantation, premature rupture of membranes, and hepatitis B. And what was also quite striking was that all the tumors were shed or expelled at delivery or immediately postpartum as either a detached tissue fragment or adherent to the fetal membranes or placental disc. And although our follow-up was limited, we were able to attain follow-up for at least 5 patients, and none showed recurrence or evidence of disease, although the follow-up interval was short. It was between 8 or 26 months. And in the pathologic review of these tumors, what we noted was the tumors were pretty small. They ranged from 2 to 6 centimeters and were well circumscribed. They were all composed of a spindle cell proliferation with variable myxoid stroma and a notable inflammatory infiltrate. There was no significant cytologic atypia. They had very low mitotic activity, and occasional tumor cell necrosis was present. And 3 morphologic patterns were appreciated, and those were this hypocellular myxoid pattern, a decidualized type pattern, and then a smooth muscle-like pattern. And while most were expelled as detached masses, we found that 1 was adherent to the extraplacental fetal membrane, or the decidua capularis, which you can see here. And then there was another tumor that was adherent to the decidua basalis, or cotyledons of the placental disc. And in the immunohistochemical workup of these tumors, we noticed that CD10 was present in all the tumors, whereas the smooth muscle differentiation was variable amongst the different tumors. We saw that ER was weakly to moderately positive in varying numbers of cells in all tumors. And what was striking was that there was this prominent, strong and diffuse PR staining, which was likely influenced by pregnancy hormones and similar to the strong PR expression seen in the decidua. And 7 of the 8 tumors that we tested showed ALK immunoreactivity, and we saw that the intensity could range even when the tumor happened to have the same fusion present. And 7 of the 8 tumors also showed ALK rearrangement by FISH and exhibited this 3' and 5' break apart pattern. And when we did targeted RNA sequencing, what was striking was that IMTs were highly enriched in TIMP3 and THBS1 ALK fusions, which I'm going to talk about in a later slide. But what was also interesting was that the tumors primarily exhibited exon 12 ALK breakpoints, which really hadn't been observed in IMTs yet. And then they also occasionally had exon 18 and 19 breakpoints. And here's just a drawing showing the various domains encoded by the ALK gene. And the takeaway from this is that all the tumors had ALK breakpoints that retain the TM, or the transmembrane domain. And they function sort of like this, where there's this retention of the transmembrane domain that's predicted to result in ligand-independent constitutive activation of the kinase domain of ALK at the cell surface, which would then lead to aberrant activation and proliferation and cell survival pathways, as well as oncogenic transformation. And in our study, it was notable that 1 of our IMTs was negative for ALK rearrangement by both IHC and FISH, and it was also negative by targeted RNA sequencing, which also screened for other receptor tyrosine kinases such as ROS and RET and TRAC. But it still very much fit the morphology for an ID or an IMT, so the diagnosis was still rendered with the idea that we were just unable to detect a genetic alteration in this tumor using our current assays. Okay, so what did we learn and how does this fit into a greater context? So pregnancy-associated, or from the study, we learned that pregnancy-associated IMTs develop during a period of extensive remodeling, and they tend to occur in the setting of pregnancy complications. And what makes them unique is that they are expelled or shed at the time of delivery or immediately postpartum, and they exhibit this strong and diffuse PR expression similar to that of the decidua. And here's just a table summarizing all the fusions that have been detected in uterine IMTs so far. And all of the pregnancy-associated IMTs reported to date are listed here in red, and those underlined are from our study here. And what's notable is that all of the fusion partners tend to work in endometrial remodeling during pregnancy, whether that be an extracellular matrix turnover or angiogenesis or cell adhesion or innervation and neuroplasticity in pregnancy. And these fusion partner genes are likely transcriptionally active during pregnancy, making them more prone to rearrangement events, potentially. So our understanding of pregnancy-associated IMTs is still very much evolving, but our data in combination with two other groups at Mayo and MGH, who also published a series around the same time, suggests that pregnancy-associated IMTs may actually be transient tumors with an indolent clinical course. And we hypothesize that these tumors are maybe derived from mesenchymal cells or the decidua and share similar regulatory features to this decidua, which enables their shedding at the time of delivery. And fertility-sparing clinical management, such as surveillance rather than an immediate hysterectomy upon diagnosis of an IMT, could very well be a reasonable option for these young patients. So there are several ways, though, that there are several ways in which the study can be improved. For one, it would have been nice to have 50 cases instead of 8, but it's hard when you're dealing with such a rare tumor type. It really helped that MGH and Mayo also published a cohort of 9 and 6 cases to sort of get more data in the literature, but it'd still be nice to have a lot more cases from other institutes published. Also, it would have been nice to have longer follow-up. The longest interval in our study was 26 months. So I don't know, but maybe we'll revisit this case series in 5-10 years and find out how these patients did more long-term. And then also we had this one tumor that was negative for ALK and other receptor tyrosine kinase rearrangements by targeted sequencing. And it would be nice to have more extensively tried to characterize this tumor either by whole genome or whole exome or transcriptome sequencing to try to find the driver event. So lastly, I just want to acknowledge our cytogenetics and molecular techs, as well as my co-resident, Megan, and Christian Kunder for his molecular expertise, and Terry Longacre for her mentorship during this project. I'm happy to take any questions.
Yeah, thank you. That was great. So I'm very interested in this topic. I find it fascinating because one thing that kind of clicked when I was reading your paper is that some tumors that happen during pregnancy are much worse, right? Like patients who get, well, I think of like breast cancer in pregnancy, that can be more aggressive than your garden variety breast cancers. But this one tends to be, or it seems to be, perhaps more indolent than its non-gestational counterpart, right? So
yeah, exactly.
So that's so interesting to me, and I hadn't thought of it as, you know, like part of the decidua, like it knows that after delivery, like it's time for me to go, kind of like the placenta. So since you're not only a GYN expert at this point, but also molecular, what in practice are you doing, not just with these, but with these ALK negative, FISH negative IMTs? Since you're now doing more of a molecular focused fellowship, do you keep going on those, or do you just assume with morphology and immunolabeling that that's what you're dealing with?
Yeah, I mean, they're pretty rare, and I've only encountered, I think, 1 or 2 of them so far. And yeah, we've just been, at least at Stanford so far, we've just been diagnosing them as IMTs, despite not being able to find a rearrangement or a driver using the current methodologies. But it'd be interesting to collect those, because there's been others published in the literature too, and try to find the driver event if there is one. Try to out a little more.
Yeah, and it doesn't seem like from your, well, I couldn't tell quite, but it doesn't seem like, it seems like that also happens in the non-pregnancy related IMTs. It happens in both. So it's not as if the pregnancy setting is really changing that as far as I know. So,
exactly.
And the other thing is, I don't think it was just looking at your data, but there was no relation between the cases that were adherent to parts of the placenta and the G's and P's of those patients, right? You had a, like, or,
no,
and,
I don't think there was.
I didn't think so either. And I just thought maybe that would be something that would be interesting to note if the patients had ever had, you know, but that I don't think that would be.
Yeah, the G's and P's. No, they.
Because I couldn't tell which, because it says expelled. They're all expelled, but there were some that were adherent. So I just thought of that. But and you did have one patient who had a hysterectomy with the
We did have
case
one,
series.
yeah, and there was no residual tumor in the
residual tumor.
hysterectomy, but
yeah,
it had been recommended that she get a hysterectomy based on, you know, the IMT being of intermediate malignant potential. So it becomes a problem for these women who are of childbearing age and want to have another child, but they have an IMT. They don't necessarily know how to be managed.
Yes, and I can say that is something that I have seen happen in real life. And I think right now it's a little bit ad hoc, but I think with studies like yours, that'll be helpful. And like you say, looking at this 5 years from now and seeing what these patients decided and what happened and what their outcomes were would be very helpful.
Yeah, it'd be great if other institutes could collect theirs and also publish their cohorts as well, just to have more in the literature. Because right now we have like 25 or so, but that's, you know, we're talking about epidemiology before.
Before we came online. Yeah,
I know
epidemiologists turn their noses up at 25 cases, but it's like, hey, we're doing the best we can. So I do see a question. Okay. This is a very technical molecular question. So we'll see. Are the genes in the 5' ECM region, TIMP3, et cetera, silenced after delivery? If so, that will likely contribute to benign behavior and even possibly regression of any residual tumor cells that are left behind, even though the tumors are expelled. That's an interesting concept.
Yeah, to think about
I don't know enough about what's turned on and off after and before, but you got a double thumbs up from that person. Okay, so you can stop sharing your screen now, and we'll just go to the gallery view. And I have a few questions for you all just about, because, you know, normally this is targeted towards early career pathologists and trainees. So I thought it would be an interesting time to talk about your experiences of presenting. So the three of you can answer as many or all of these as you want, but I did a platform presentation when I was a GYN pathology fellow, and I found it a very stressful experience, but I have a fear of public speaking. So do you all want to talk a little bit about how you prepared for your platform presentation and what it was like to present at USCAP? We can start with Dr. Dibbern since you went first. Oh, I can't hear you for some reason.
It was terrifying. No, it was a great experience for learning, but I also get really nervous with public speaking. But we were kind of in a unique situation. So we had all our stuff teed up and ready to go in January because I was doing an international elective in February. And one way we prepared is I practiced the presentation with our PowerPoint and, you know, our talk with kind of a mixed audience. So faculty in the department, some of our CP faculty, we had our tie-in from like our immunology colleagues. And so we got kind of interesting feedback. Some of the initial feedback was we weren't being clear enough with like what part of the immune system we were talking about, being a little bit too vague. And so that in-house constructive criticism really helped like tee up some of the detailed finer points of the talk.
Yeah, I also appreciate, and you had like an self-imposed early deadline. It's brilliant. It's brilliant. Everyone should do that all the time. Word that it was possible, right? Yeah.
Practice. My coworker that came with probably knows my talk by heart.
That's good. It's a good friend. What about you, Dr. Stolnicu? How did you prepare, and what was it like for you to present?
Well, fortunately, it was not the first time I was presenting, so I got used somehow, but it's difficult because it's not my native language to start. And then, you know, jet lag, I have to travel, and but it's also so interesting to be there, to be part of that Congress, which is probably the best in the world. And how did I work for the presentation? Where Dr. K. Park, you know, encouraged me a lot and helped me a lot. But it was also the result of the ISCC study. You know, so it was like things and information coming out of that study that were very helpful to clear our mind and, you know, and deal with what we had. So that was also very useful. And then for the publication, same, we just follow all the steps, and we really wanted to publish it very, very fast, because we know that this is important data that the clinicians should use. And then, as Dr. Park said, collecting more cases would be very useful in the future, because it could add more information. So we are working province where we're getting more cases, actually.
That's great. That's great. And Dr. Devereaux, did you want to talk about what it was like to prepare and present at USCAP?
Yeah, I think it helped for me too, because I had already written the paper before going to USCAP and it had been accepted and embargoed. And so the data had already been formally summarized, and that really helped to put together the talk. And then also at Stanford, we do like a little, it's a very low key thing, but a practice talk. And that sort of helps highlight the awkward parts of the talk and helps you to like improve the flow, because presentation is so much easier to give when the story transitions and flows well.
Yeah. And I, back when I did mine, I know I had practiced so much that by the time I got there, I had to remind myself not to sound like a robot, because I was like, I knew what I wanted to say and when I wanted to say it. So I had to, take some deep breaths. And also I've been told that I talk too fast when I'm nervous. I don't know if any of you do that. It's the default setting for the Natalie robot. Okay. And so this won't apply to Dr. Devereaux, but between, I'm interested to know this, because you get feedback when you're doing your platform. Did Dr. Dibbern or Dr. Stolnicu, did you receive any feedback that you used to change what you were doing, or did you collect data between, when you presented and when you published, or how did that work? And Dr. Dibbern, you can go first if you'd like, since you were first. Yeah.
Similar to Dr. Devereaux, we had our manuscript teed up and submitted before the presentation.
Perfect.
Part of the feedback that we got from our in-house faculty and staff, though, went into like teeing up how the presentation went. And we kind of approached the talk with a story in mind, even when we submitted the abstract, which made it a lot easier to go from abstract to presentation to manuscript.
I like that, having a narrative. Yeah. And what about you, Dr. Stolnicu? It sounds like you were you knew what you wanted to say when you got there.
Yeah, exactly. So we had all the data, we had all the cases by presentation at the USCAP, but then what I found very useful were the questions from the audience. The questions were so right, that like, for example, where was the site of recurrence? Where was the site of metastasis? And, a couple of data coming out of those questions we have included in the final manuscript that we have submitted after the USCAP.
Yeah, that's great. And also maybe if you had, some of you had already had your papers done, which kudos to you, but maybe it gave you ideas for spin-off projects or, ways to expand your study. So that's nice. And then I just thought maybe we could, as our final question, for those in the audience who are either aspiring, pathologist trainees or folks who want to get published or who are thinking about getting into research, I find in the process of mentoring that I end up doing a lot of talking people down from thinking that research is something that they could never do, right? Because it's just so opaque or something. So you all have done it, you've done it well. So do you have any practical tips for manuscript preparation? When you get stuck, what do you do? Things like that. So we can start, why don't we start with Dr. Devereaux? This time we'll go backwards.
I enjoy doing research, and I encourage trainees to do research because it's a way to learn something, and see a bunch of different cases with your mentor and really understand a tumor well. And then also too, when you're doing research, it's important to stay organized with your data and case collection. Do a lot of reading before you start writing too. And also it's helpful to study other papers and kind of look at how they lay out their tables and their figures and make note of styles that you like.
Yeah, I sometimes have table envy. Does that ever happen to you? You're reading a paper and you're like, oh, that's a really great way to put that.
I'm like, oh, I should have done my table like that.
I know. What about you, Dr. Stolnicu? Do you have any practical tips for us?
Well, first of all, never give up,
Okay, that's good. Put that on a t-shirt, yeah.
But also think about, when I was reading before the ISCC and the new classification, WHO classification, I was reading the 2014 WHO classification, and I was, I wasn't very, it was not very useful for me when I was reading that text on how to diagnose this kind of tumors. Actually, I was probably having invasive smiles before and didn't know how to diagnose them. So, this perseverance and this, this ambition to go on and to make clear first of all for yourself about what you are reading and what you are dealing with every day. And of course, go on and get multiple cases and try to publish them and change things, which can have impact on the management.
Yeah, that's really important. You talked about sort of wanting to publish quickly because you knew it was going to benefit patients. And there's no better reason to put pen to paper, or I guess fingers to keyboard, than that really in medicine. What about you, Dr. Dibbern? What are your tips?
I feel like Dr. Devereaux and Dr. Stolnicu are maybe more advanced than me.
No, because you're a trainee and you're doing it. So we want to hear from you. Yeah.
I think you're about talking people down. It is really scary. Like the people that do it well, they make it seem very easy, but you have to remember that they've had years of experience. They had mentorship to get to that point. So I don't know, acknowledging the imposter syndrome that you can make a contribution to science. It is worthwhile. You're not overstepping by trying to make new discoveries, and finding a mentor that will support you through it.
That's important. Yeah. And since we have you on the call, Dr. Park, Dr. Mills, would you like to say anything? I see Dr. Park, you just unmuted yourself, so maybe you're ready to go. Go ahead.
Well, I'd like to say that for the trainees out there or the junior people, it's okay to upmanage your mentor, because I'm sure we've all had experiences, and I'm certainly guilty of being on that end where, you've got things ready, you've sent them the draft, and you're not hearing from them, and you know that they're busy and you don't want to bother them, but you got to push them. So, sort of up managing your mentor is a really important part of being a good mentee. And mentors do actually really appreciate that, because we get busy and, things fall by the wayside, and there's always another fire that needs to be put out. So I think for me, getting things published has been mostly because I've been really well managed, especially by Dr. Stolnicu.
That's a healthy relationship right there. I like that. It's a hard skill as someone who feels they're interacting with someone not more senior age-wise, but maybe just in terms of experience to kind of do that. I find that setting deadlines is helpful. Like actually saying like, I'm going to do X a month from now. And if I don't, whatever, then I'm going to assume everything I did is perfect. And a lot of times that gets people's attention. So what about you, Dr. Mills?
Yeah, I think one of the best things that or most successful practices I've seen is when the mentor and the mentee sit down and look at their schedules, because most of us in academics have a schedule that looks like this. And often the residents' clinical schedule is not synced with the faculty's, service schedule. And so they'll keep being ships in the night. And so I usually sit down with my mentees and say, okay, I'm on service this month. So do what you need to do, work in the background. I would love to, I have time and bandwidth to help you in the month of March. So if you can have something for me to chew on in March, I can move it along in that month. And so we sort of play like pass the baton a little bit, but that requires communication about when you have bandwidth and when you don't. I think too often people are out of sync and they can't quite meet at a time to be, move things forward. And yet Dr. Dibbern is she's hungry, right? You want a trainee who has the hunger, and it's not common to find people who are really excited about research in a way that they really are willing to drive it. So it's really fun working with someone like Megan, who sees herself in academics. She's going to be very successful in academics. And so she brings the fire, and then that kind of stokes my fire, and we can get each other really excited about the project.
That's nice. That's always nice to have a trainee who comes with some fire, because as you get busy and like Dr. Park said, things get pushed down your to-do list. It's nice to have someone sort of knocking them back up to the top, right? It's like the squeaky wheel getting the grease. So, well, I really appreciate you all doing this. I hope this got everyone in the audience excited for the USCAP meeting next month. I'm really looking forward to hearing from all the presenters then. So thank you all so much for coming. I really appreciate it. And anyone who's still in the audience, please fill out the evaluation on your way out, because I read them all and we use them to change the format and make it better for everyone. So thank you all. Thanks for coming.
Thank you so much.
Thank you.
Thanks.
Bye.
Bye.